Hey, everybody, this is Dr. Josh Funk with another episode of the Strength and Knowledge Podcast. Yes, I am here masked up. My original plan for today had me in a situation where I was not going to have to be masked up to do a podcast interview, but this is my first masked up podcast interview. Nonetheless, I am here with Laura Opstedal of Build Physio, and I'm extremely excited to have her on today, just with her path in entrepreneurship, her focus on orthopedic and sports rehab, but nonetheless, welcome, Laura.
Thank you. This is actually the first podcast I have ever done, so hopefully I won't butcher it.
All right. Well, yeah. I will do my best, as I always try to do, is just take care of you and make sure that you get to share all of the good things that you have going on. So we always try to start with really just talking about the path to the profession. What was that like for you?
It was pretty boring. I'm definitely not one of those PTs that had a significant injury in the past. My significant injury came 2 years ago when I tore my own ACL, but my dad was a firefighter and EMT, and I just always liked kind of the rescue and medical part of that, and sort of got turned on to the profession playing sports in high school. Not as an injured person, though.
Yeah, which is a little bit unique, right? I feel like a lot of people, at least that I'm sharing my space with here at Rehab to Perform, had some kind of injury that pushed them in that direction. Not only did you find your way in PT, though, but you also found your way to entrepreneurship and opening up a private practice. What kind of sparked that in you?
Oh, man, I really feel like I'm sort of the later career, PT, entering into that sort of late in the career. I've been out of school for going on 20 years. Never thought I would do this. It's always been a thought, but, as time went on, it was one of those dreams that I just couldn't bury, so to speak. And, I sort of played around with opening a clinic versus going back to school to get a PhD, and ultimately decided to open my own clinic.
And with Build Physio, you have what I would call a little bit more of a modern setup, turf, a lot of things that would look more like a fitness facility with regards to equipment. Was there anything that inspired you for this particular facility layout? And is there anything that you feel like really should be a mainstay in PT clinics that maybe isn't currently?
I work with a lot of athletes, and I wanted my clinic to be comfortable to them, comfortable and familiar and less medical, so to speak. And so when I was imagining my dream clinic, I was really catering towards an active person or an athlete, as far as equipment and the decor. But I found that, my patients that are everyday people also enjoy it. It has sort of a motivational feeling to it. And again, less medical or sterile.
I honestly use that word frequently when people ask me. I'm like, I'm trying to avoid being sterile. The white wall, private treatment room, very plain wall. Like, I don't want to see a whole lot of skeletons or anatomy things all over the photos. Like, I want people to automatically think I'm here and I'm actually going to work out at some point.
Right. And no ugly art.
No, please.
I mean, how many clinics do you go into and you're like, where did this come from?
Yeah. And how is this relevant and how is this beneficial? I mean, I hate to say it, but I've got some interesting art behind me, but I'm also not in one of our facilities today. So for you, I mean, your place is laid out perfectly for stuff like ACL rehab. You had your own experience with the rehabilitation process, and I know it is a population that you serve a lot at your clinic. What are some staples to a very, very good return to sport testing battery when it comes to ACL rehab? And I know that's a loaded question, but where would you kind of start, and what's your framework for decision-making for return to sport?
I had the opportunity to work with some surgeons right when I moved to Bozeman about 7 years ago. And with that, I saw a high volume of ACLs and did 2 surgeons returned to plays. So I don't know how many I've done, hundreds probably. You know, it wasn't unheard of to see 5 a week. And so I developed really my own battery of tests. And I also question a lot of the ones that have been done in the past, especially hop tests, not a huge fan. But, you know, as I used a handheld dynamometer, I had it in an inline setup with these guys. I enjoyed the data I got from that and realized we could do so much better rehab wise. And when I opened my own practice, I ultimately decided to buy an isokinetic machine, and no going back now.
Yeah, and for you, with the isokinetic machine, when I think of isokinetic, I think oftentimes of more open chain exercises. Is that fair?
Yes. Yep.
In terms of what's actually going on with that. Yeah.
Yeah.
For people who don't use that regularly, at what point do you start tying that in to start benchmarking, say, quadriceps strength or hamstring strength? And then what type of values are you then looking for near the end stages of rehab?
We use ours right away. No, there's a 5-pound threshold to get a reading on it when we're doing early isometrics after ACL. And some people, you know, in the first week or so can't get past that threshold. But, you know, we're on it the first week. And typically mid-range isometrics first, and then, you know, depending on the graft, which is a fun hot topic, we'll go right into eccentrics, sometimes isotonics, but I don't really do a full isokinetic test until 12 weeks. I stick to the isometrics prior to that, as far as testing goes.
Got it. And then at that 12-week mark, I mean, what things are changing, not only with your testing and maybe some other things that you're trying to do to, say, beat the test?
You know, I think I have a good idea where they're going to be at as time goes on, because using that machine is you're constantly collecting data. And so you should see those, you know, foot-pounds increase over time. And you know, some people have a little bit of fear to push through the range, or, I mean, it really depends on the person, I would say. But the ultimate goal would be to get somebody to push out, you know, the equivalent of their body weight or greater, and then have that be symmetric side to side. So I worry less about symmetry until we get to the end, until I know that the contralateral side is at body weight or greater. You know, because we know that side's weak too. But I'm also looking at eccentric quads, which has been kind of fun. And that should be greater than your concentric strength.
And that makes sense. And then for the people who are doing their best to also look at the hamstring ratio, how is that parallel being drawn as you go through the rehabilitation process? Are there any particular factors that you're thinking about early, mid, or late stage?
That would make it different, or as far as measuring goes?
Measuring, make it different, anything that you're potentially doing differently from a training standpoint as well.
You know, with the isokinetics, you get a concentric quad and hamstring, but I also like to measure the hamstrings eccentrically towards the end, because that's how they function normally. And my ratio would be more of that functional ratio between concentric quads and eccentric hamstrings. So that would be like a 1-to-1 ratio. And we can do a lot of cool things as far as training hamstrings on the isokinetic machine. Differences between graft types. I mean, with the hamstring grafts, which I don't see a whole lot of in this area, they tend to be a little slower. And unfortunately, if I'm seeing somebody that's like a revision or a re-tear that had a prior hamstring, those deficits are still pretty obvious when we start looking at them.
And you alluded to it a little bit earlier about graft selection. I know there's still some discussion there, sometimes it varying between genders, obviously the age of the individual and the particular activities that they're engaging in. What recommendations or discussions do you find yourself having surrounding graft selection?
I think that greatly depends on, like you said, age and gender. I don't typically recommend a hamstring graft for a female that's under 25. Unfortunately, hamstrings, I would say of all the re-tears I see, a good number of them are hamstrings, but I'm not opposed to them at all. I think you can get a guy that's really, really active and he doesn't play a level 1 sport or isn't a collegiate athlete. They do really, really well with hamstrings. And they're honestly a little bit easier to rehab. Their quad strength comes back, a little faster than the other graft types. But here in Bozeman, I'm seeing mostly quad tendons, patellar tendons, a splash of hamstrings, and probably equal amount of allografts.
Is that something you would expect to see? I mean, I'm under the impression that you would agree with a lot of that.
I'm from the Tacoma, Seattle area, and I feel like most of my career was heavily weighed towards hamstring grafts.
Okay. Got it. I mean, that's something, admittedly for us, I think we see a lot of patella tendon grafts. The one thing that I will say that a lot of people seem to steer away from, which I always think is interesting, the rationale behind I'm going to choose hamstring because the patella tendon graft, you've got knee pain. And I could really overgeneralize here. And I could say, well, with good rehab, we're probably not going to have as much of that knee pain. Now, it's not to say that we're not doing things differently as a result, but a lot of times, whether or not we can put it on a tendinopathy continuum or regardless, we're cutting a piece out of the patella tendon, and we're doing things where, there's a loading process, right? Maybe there's this ache, educating people on that the ache is normal. What are some things that you're doing early on to kind of frame up why they need to feel certain things and what you're trying to accomplish during that, say, first 3-month period?
Per graft type or just in general?
Just especially for that patella tendon, where maybe you're doing some isos and maybe you're educating people on the fact that they need to feel a little bit, maybe of an ache in a particular area as you build tissue during your isometric progressions.
Right. I think if you push them too far into pain, they're just not going to push hard, and that's why when we do testing and they have pain, I'm not really sure it's a very accurate test. I don't think we're capturing the max torque they can produce, but a little bit of pain is to be expected. And during the activity, if it's, like low level 2, 3, 4 out of 10, it settles by the next day, much like you would treat a tendinopathy. I lay that groundwork ahead of time so there's not any surprises or anybody pissed off at me.
Yeah, and I think that conversation is critical, and something that I think that we've been doing more and more, like outside of your open kinetic chain isos early on, right? I mean, you could do things that you mentioned mid-range. I know sometimes we can get into the semantics of mid-range depending on where they're at in terms of how much flexion they actually have at that point in time. But I mean, outside of those open kinetic chain seated isos, are you doing things like, say, single leg wall sits, iso split squats? What kind of isometrics are you layering in during that early part of rehab?
Yeah, I mean, obviously the home program is really important. So early on, we'll do depending on range, a mid-range, 60-degree, kick the foot into the wall, hold, 45 seconds, minute rest. And I like to do that with NMES. So my patients usually buy one ahead of time. If I'm lucky, I see them pre-surgery and I lay all this out ahead of time. So they come in, I program the NMES unit for them. And, as soon as they can get their knee bent enough, we're doing mid-range isometrics. If not, then they're doing them in extension.
Yeah. And I think that's just in line with some of the stuff that I've seen with later stage rehabilitation, later stage isometrics. Is there anything that you find yourself doing, or do you get to a certain point where isometrics are not as prevalent in the routine?
Oh, I probably only use them in the first month, actually.
And
And then maybe later on when they're, at a sticking point, perhaps, in a squat, we'll do pin squats at end range or something like that. Cause, the further inflection people are, if you do like a half kneel, see how fast you can get up, it's not really a test, but I look at that. They would really benefit from an end range flexion isometric hold. I would call more a hold than a ISO.
And what the pin squat, are we speaking the same language when I would call it almost like an overcoming squat where they're pushing the bar up into the rack or
yes.
Okay.
Yep.
Got it.
Or I like the trap bar. You can put the trap bar down low and pin it in the squat rack and have them, try to push through the floor and come up.
Okay. And then for the people that are trying to understand the end range ISO that you're referencing, can you describe that a little bit more?
End range meaning, you're at the bottom of your squat, and maybe you hold that at that point. I like to do that more in a split squat because, the regular squat side by side, I feel like I can't see them cheat. I have force plates now too. And it's pretty obvious that people lean away, even though you physically can't see it. They're definitely unweighting that side. So I think in a split squat or a single squat, you can capture more accuracy on what they're really doing.
I would agree. Sometimes it's tough, especially if I'm just viewing them from the front to see shift. I've actually gotten better at looking at them from the side. And despite them looking balanced from a side to side standpoint from the front, what I'll see when looking at the side is some kind of a rotation. And I will actually see from the side, like one knee is further far forward. So we kind of going into that quad avoidance on the one side where it's almost, they've got a more hip shifted strategy on one side, and they have a more maybe shared strategy on the other. When we talk about things like quad avoidance, is there anything else that you're seeing throughout the benchmarking process or through some of this return to sport criteria in which you're seeing things pop up that remind you that you need to go back to training certain things in certain positions? Or what would you say that you've seen with regards to quad avoidance outside of just, jumping or landing mechanics?
Oh man.
I know it's multifactorial. You could probably go a bunch of different directions with that.
Yeah. I mean, I feel like we are all fighting a hip strategy for the entire duration of the rehab. And so when that's popping up with a particular thing that you're doing, they may just not be ready for that particular thing that you're doing. If they're trying to compensate in some nature, maybe it needs to be modified or made easier until you feel like you're seeing more of a knee strategy and then build up from there. But I think it's just a constant, modification or manipulation of exercises to avoid a hip strategy.
I agree entirely. And I almost will refer to this as kind of like a choose your own adventure book. And I almost kind of go like, okay, like we chose this exercise. You chose the wrong page. Okay. You have to go back to whatever page, right? We're cheating in the choose your own adventure book. But that's the best part about rehab is like you have stuff that holds you accountable. So you get to a certain point, you're like, oh, I thought this was a good idea. And then you look at it, and you're like, whoa, not a good idea. Okay. How do we go back? I must have missed something. I think if we get to, right. Yeah. And I think if we get to things that people will typically miss, you have to look at some of the objective measurements that you are using. Obviously, we're talking a little bit more, I think, when we look at strategy. Sometimes you can eyeball it. Sometimes you can use certain apps to look at certain angles. With return to sport testing, is there anything that you think is a little bit more unique to your approach or things that you're doing outside of having access to things like a force plate and isokinetic testing?
I mean, I kind of look at it as an algorithm. I don't really want to do a bunch of other tests until my isokinetic testing shows that they're symmetric. I don't, it's overly simplified, but
yeah,
with a lot of the functional tests, if they're my patient, I know if they're going to pass or not, because I've done a lot of the similar things during the rehab. So for me to like do a return to play in one visit and make a big decision like that, I just don't think it's realistic. I think you need to consider what they've been doing, what you're allowing them to do at practice, or whatever activity they're doing. It's more of a continuum, but I mean, I do have my favorite tests, like a single leg drop, vertical jump, or something like that, where you can compare side to side, mostly to show the patient, because they can feel that right away if they're not ready. There's hesitation, they're stiff when they land. That's an easy one to do along the line. But yeah, it's more of a continuum for me. It's more of the process than the one return to play visit.
absolutely. And I think what I could speak at least to that is I feel like I knock off almost like a curriculum. It's like, all right, I'm knocking off these early elementary school level tests. Like, okay, full knee extension, full knee flexion. I get to a certain point where I can do some kind of like an anterior step down. We've done a single leg wall sit to, a certain angle, ideally at least like 60 degrees for 45 seconds. Then we get into some of our Y balance testing, ideally hitting that very, 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 very early before we then get into later stages of testing. So I'm with you. It's almost like we've accumulated data points where I've said, all right, hit that, next one, hit that. And you're trying to get into these higher level, high school type tests or more sports oriented testing as you go along, where you're getting into stuff like, okay, we've got hop testing, we've got 5-10-5 testing. Can we get into some more demographic-based norms? We've actually been doing more demographic-based benchmarking to at least give us an appreciation for how this individual might compare to some other people. I know soccer's, a big passion of yours, and there's some data out there to compare soccer players that are at the college level in terms of certain more athletic-oriented tests. Do you have anything near that end point in time that you see people maybe typically miss, or any kind of clinical pearls at the end as this individual is going back to their sport, maybe even for soccer?
I mean, I think the biggest pitfall in the rehab, we already touched on this a little bit, is advancing them before they're ready. The knee's just not ready for a particular thing, and so they develop a compensation, and because we all want to get to the fun stuff, but I think you need to look at it by individual. There's just some people that are going to progress really slow. You could be the best PT in the world and it might take them 2 years. There's other people that are going to progress really fast for some genetic reason probably, but I think it's important to look at the individual, the sport they play, and even within the sport, the position.
I agree. I mean, for me, if I'm overgeneralizing here and kind of putting people into buckets, that people that typically will take a little bit longer are individuals that maybe have a, higher body fat percentage. Overall conditioning is something that they struggle with. If I just talk about relative strength, right, their ability to be competent with self is a struggle. And then outside of that, I mean, you've got the growing athlete that is still acclimating to their body. They're a little bit more of that baby giraffe, like where they just look like they're struggling to put one foot in front of the other. Once again, struggling with just some baseline competencies as they adjust to their new body. But at some point in the process, I know that you probably start to communicate with sports trainers in the area and sports coaches. What recommendations do you have for initiating that conversation? And then is there anything that you are frequently saying to both the athlete and or maybe just the coach?
I think you need to lay that groundwork right away and just reach out to the coach. I've never had anybody that shut me down. if you reach out and want to discuss the athlete, because it really does they want to know what they're able to do at practice, and so if it's a every other week conversation you have on the phone to allow the athlete to do a little bit more, or maybe the coach notices something and they can report back to you. It's actually a little easier with college athletes because that stuff is all in place already. You just need to talk about it, every couple weeks or month or day, depending on the person. But everybody needs to be on the same page and have realistic expectations. Because unfortunately, you still have some coaches that think this is a 6-month thing and their athlete will be back. Or worst case scenario, you let them do some things at practice and the coach forgets or thinks that the person can do something, because can and should are two different things. But yeah, reaching out in the beginning and keeping an open door for the athlete, the family, and the coach.
I think the biggest thing that I've had conversations with coaches about is really understanding the buildup of volume as we also start to build up intensity. And they might think that just because they are returning to the practice field, that they're able to handle a full 2-hour practice and also handle the intensity at which everybody else is practicing. How do you layer in conversations about load management so that the athlete understands that process as well, and then inform the coach about that about that topic too?
So for instance, I'll just give an example. With women's basketball, say at the college level, or even like volleyball or something, I've gone to the practices to see what their layout is, get familiar with the drills, the length of practice, what their schedule is during the week. And then I can get an idea week by week what I allow them to do, or just make sure that it's not a big bump up in activity. But I think for people that are unfamiliar with a particular sport, or even if they are, it's great to go out and watch a few practices just to understand, what the demands are, or what the layout is, or drills that you can probably replicate in the clinic.
I love that. And I think that's something that I found myself being able to see that a little bit more, both where I first got exposed to rehab, which is when I hurt my shoulder when I was at Ohio State playing lacrosse. And you get to obviously be there and everybody's practicing kind of in the same area. So you get that exposure. And I think obviously the beauty of that is it's very, very easy for you to pop into that environment and just, hey, watch a practice. But for people in the clinic, sometimes that can be a lot more challenging. And unless you're really actively seeking that out, even if you just pop up stuff online, like I didn't know much about cricket and I had somebody come in and they're playing cricket. I don't even know where I'd go see a cricket match. You know what I mean? Outside of asking them kind of where they were doing their thing. So I pulled it up online, I watched it, and I actually started to better understand the demands of that sport. If we talk about demands of sport and then eventually getting to a point where we're not working with that individual, I know you have some plans in place or some opportunities to stay in contact with your patients or clients after they're done with you. What do you have in place for them after they've been, quote unquote, discharged or graduated from spending, more regular time with you?
Man, that's another loaded question. I think it's easy. You've just spent, 9 months with this person and they almost become a friend. I use that a little bit loosely, but I think that's just a natural thing for me to reach out, if they pop up in my head, and, I'll reach out, send an email or a text to make sure everything's going okay. And if not, then, offer to come back in and maybe reassess, but I don't really have to think about that too much.
Fair enough. Some things come very, very natural and are very intuitive for some people. So I appreciate that. And I appreciate your time today. I want people to be able to stay in touch with you and ideally just connect with you. So where are the best places for them to connect with you and engage with you?
Oh, probably Twitter. I'm a frequent user of Twitter, as you know.
Absolutely. And what's your handle?
So, at Laura Opstedal.
Okay. And for everybody, and I know that I butchered this previously. Okay. So it's at Laura, and then her last name is Opstedal. So give her a follow. She's definitely very, very active on there. I know that you've had some challenges associated with COVID this year, as I can relate. And I'd love to catch up with you a little bit more on that offline. But I do appreciate your time today. And I know the listeners will as well. So thank you.
Thank you so much for having me.
Absolutely. Have a great weekend.
You too.